Objective of this talk, first, introduction to the topic, and especially I think everybody needs an introduction to the title as well, because many doctors, they call me and ask me, it sounds like Greek. Then I said, indeed, it's Greek, but you're going to enjoy the rest of the presentation. And then I'll be talking on magnitude of the problem, and third part of the presentation will be on how to minimize the errors, and the fourth part of, or the final part of the presentation would be how to manage medical errors. Particularly, I'll be, as many of our doctors are not very familiar with the critical incident reporting system, and also WHO initiative regarding this. I'll be touching on those two things especially. Okay, introduction. So we'll be talking about the patient safety. So primum non nocere, or in later part of the Greek, it's also known as nocere. Uh, or every physician are expected to, all the physicians are expected to uphold the specific ethical standards declared in the Hippocratic Oath. Swearing a modified version of the oath remains a ritual of many medical schools world over. Uh, Not only violation of oath carry ethical issues, but also it can cause legal issues as well. So one of the oath is known as primum non nocere. That means we promise to abstain from doing harm. Is also known as either help or do not harm the patient, or simply it is known as uh, first do no harm. So the million dollar question is, do we cause harm to patients? Smoking kills, and hospitals as well. This was a very important article published in British Medical Journal in 2016, and which highlight the fact that third leading cause of death, not in Sri Lanka, in United States, was medical errors. And the author suggested medical error should be listed as one of the cause of death in the death certificate. Many doctors, they don't believe in medical errors, like this doctor who says medical error is nonsense. Your hysterectomy was a complete success. But patient says, I came in for tonsillectomy. So we might get irritated when we see media criticism regarding medical errors. So probably you are very familiar with these books, and every day we see the media criticisms. Okay, before we proceed further, which one you think is the safest place to be? Is Addenbrooke's Hospital, Cambridge University Hospital. Next one is a Concorde flight, and is a nuclear plant, and is a European railway. Which do you think is safest? In your right hand corner, the most safest place, or the safest things are European railways and also nuclear power plants. Scheduled airlines are also very safe. They are called ultra safe, very, very safe compared to healthcare setup, which are very dangerous. This paper published in November 1999 by the Institute of Medicine USA, and it was beautifully written, and the author starts saying that, starting the article saying that healthcare in the United States is not as safe as it should be and it can be. At least 44,000 to 98,000 people die each year due to medical errors. So this brought the medical errors to much public attention. So over and over again, the fact that medical error was a leading cause of harm, and the mortality and morbidity was brought to the highlight. This was published in 2015. High-income countries, roughly about 1 in 5 patients are harmed in the care setting. Countries like us, 2 out of 5 patients are harmed. That's roughly about 40%. So you can imagine the gravity of the issue. So to give some more insight into the magnitude of the problem, if you don't believe it is the third leading cause of death, certainly it is one of the 10 leading cause of death and disability world over. In the developed part of the world, 1 in 10 patient is harmed during hospital care. What is more important is, even the developed country, 50% of them are preventable. Each year, 134 million events occur in hospital, especially in the lower middle income countries, resulting 2.6 million deaths. And in the lower middle income countries, 25% of the patients are harmed in the healthcare. If you think hospitals are the bad places to be, what about the OPDs? These are more dangerous. 40% of the patients are harmed in the primary care and the OPD. 80% of them are preventable. What about the economic cost? Social cost for patient harm can be valued at 1 to 2 trillion US dollars per year. Mind you, it's a trillion US dollars. In 2017 and 18, NHS paid 1.6 billion sterling pounds as compensation. 15% of the hospital expenditure is wasted due to safety measures. If you are not familiar with setup, our budget deficit is 1.5 trillion in 2021. So the amount wasted is 460 trillion rupees. So you can imagine the wasted. So in summary, patient harm is a leading cause of mortality and morbidity. It not only affects the patient, it affects the patient, family, medical staff, and institution. And not only the institution, it's also the medical system. The magnitude of the problem is huge. It's a growing issue as we come across more and more medical errors. Economic cost of safety lapses are enormous. So it has an impact on the patient. It causes death, disability, and discomfort to the patient, and loss of confidence, depression, stress, and the lack of productivity for the healthcare staff who committed that medical malpractice. And to the hospital, it ruined the reputation and the confidence in the system. Because we live in this country and the healthcare is free, we don't see the impact of reputation and the confidence in the hospital. If it is a private hospital, definitely you have to close down the system and go. So everybody, it causes economic loss, reduced productivity. Very important factor is its preventive. So next part of the presentation, we are moving on to the next part of the presentation. How does the patient safety evolve? Evolution of the patient safety. Following the Second World War, people started realizing, hospital, there are some hazards like fire, equipment failure, and patients are falling from the beds. But healthcare staff are considered as divine creatures. So evolution. So doctors are considered as next to gods, right? People realize, oh, it's not only on the it's not the doctor who heals, it's the God heals, and the doctor takes the fee. Then the status has come down further. People realize, just human being, your doctor is not God, right? And finally, now it has come to the status where doctors are equated to serial killers. So that was in a lighter vein. And then, the studies from 1990 began to view the safety through a different angle, different lens. The term medical error was coined. That further terms which are coined with the medical error were incident, critical incident, adverse event, serious untoward incident, never event, near miss, and close call. Well, we are talking about a specialty or a field which has less than 30 years of history. So it started around 1990s, and so before we move on further, let's consider whose safety we are talking about. It's a hospital safety. Safety, hospital safety means it's a property of the hospital, people of the hospital, and the place of the hospital. What do you mean by place of the hospital? It's infrastructure, electrical, mechanical failures, and the fire. In fact, I didn't realize the importance of fire till we had a fire in our MRI suite. We had a great time in moving our patients to safe location. We didn't have any plans for fire. In fact, we didn't have way to evacuate the patients. The property, what are the properties of the healthcare? It's the assets, equipments, and the stores. So that's also important to protect them, right? What do you mean by safety of people? It is not only the patient, it's the visitors. Hospital should be safe to the visitors as the care providers, staff. Every year, 17th of September is declared as a Patient Safety Day by the World Health Organization. And this year theme was Act Now for Safe and Respectful Childbirth. I think this should be the motto of each and every hospital in Sri Lanka. A world in which no one is harmed in healthcare and every patient receives safe and respectful care every time, everywhere. So this should be adapted as each and every ward, hospital, and the units. Then we move on to the next part of the presentation: medical errors, types, and specifically, I'll be talking to you all about the types, and especially I'll concentrate on the diagnostic and the management error. So errors, the definition of error, and uh, errors could be due to problem with knowledge, skills or training, attitude. It could be stress or due to personality, due to unfamiliar environment and the system. If you think error is limited to newcomers of the field, certainly not. Even the experts can get into trouble with errors. Before move on further, I'll just give a quick introduction to the anatomy of errors. It will be a skill-based errors, which this is important for administrators to know which kind of error occurred in your unit. So, for example, what is skill-based error? Which is also known as it could be automatic or the routine error. For example, a nurse sits on the syringe pump to see the dilution was wrong, so patient gets an overdose of drug because she has just sets on the routine say 1 ml per kg per hour, but to see the dilution was wrong. Another type of error is known as rule-based error, where there's a training and expectation is there. For example, if you intubate, use end-tidal carbon dioxide to see whether the tube is in the trachea or not. So you might get into trouble not using EtCO2. When you have a problem, then you don't know how to confirm the position, the site of the place of the ET tube. And the third kind of error is known as knowledge-based error, where you are expected to have conscious decisions. For example, in an intubated and ventilated child, you see the ETCO to 0 and you don't suspect dislodged tube. So these are the kinds of error. For clinicians, I think errors can be classified into another easy way, close to your, sort of it's easy to remember. For example, medication error, surgical errors, diagnostic errors, equipment failures, infection errors, blood transfusion errors, and other errors such as radiation errors. So this was not taken by the medical textbook. It was taken from the medical lawsuits from the lawyers' offices, right? So the commonest error is the diagnostic error. So we as pediatricians, most of us are pediatricians or trainees in pediatrics, so we are more prone for this error. Surgical errors, you might think that we are not part of this one. No, because we refer patients to surgery and we take care of patients who undergone surgery. We can be part of this error as well. Of course, we are part of treatment errors and birth errors. Because we resuscitate and we take care of newborn babies, we can be part of this one as well. So there's no way to escape. Medication errors, of course, we can be part of it. And finally, monitoring errors. So all of them are very, very relevant. So the commonest are diagnostic, procedural errors, and the treatment errors. And the birth errors, then medication and the monitoring errors. Okay, we'll just go through the common type of diagnostic errors you can be held responsible for. Delayed diagnosis. So delayed diagnosis, for example, you see a patient who presents to you with fever and you're struggling to make a diagnosis and finally the patient collapses and then you diagnose dengue shock syndrome. So the delayed diagnosis for which you may be held accountable. Failure to diagnose an unrelated illness. For example, you have a dengue patient, you have diagnosed and you treat, and this patient is having severe bleeding tendency. To see there was a coagulation disorder, undiagnosed, which is unrelated to the current diagnosis. So you can be held responsible for that. Third example is failure to diagnose related disease. But the second one I told you, unrelated disease. The third one is failure to diagnose related diseases. For example, you diagnose and treat pneumonia in a patient and who is poorly responding to treatment, and to see there's underlying immune deficiency. So if you don't diagnose, you can be held responsible for that. Misdiagnosis, you don't make diagnosis, the pathologist or the JMO makes the diagnosis in the post-mortem room, so definitely you are responsible for that. And failure to recognize complications. For example, there's a patient who has gone into shock, then you don't suspect and diagnose internal bleeding. So then you can be held responsible for that. And misdiagnosis. What do you mean by misdiagnosis? That means the actual diagnosis is meningitis, but you are treating this patient as Kawasaki. So it's a misdiagnosis. So all of them you should be avoid. Otherwise, you have to you can be held responsible for these errors. If you want to improve your diagnostic skills, you should read this book, Improving Diagnosis in Healthcare. So probably you would agree with me, diagnostic errors are widespread in our practice. One side of the problem is overdiagnosis. For example, in dengue epidemic, all the low platelet counts are equal to dengue. I have seen patients with septic shock treated as dengue, meningitis with the DIC treated as dengue. HUS with hypertension treated as dengue. So this overdiagnosis is also a problem. Underdiagnosis, for example, even at the peak of dengue epidemic, when there's a slightly low white cell count and platelet count, they don't think of dengue. So that's also other side of the coin. Not only complicated, I am not talking about the very complicated diseases that that we miss, but I'm talking about the very simple presenting complaints like diarrhea, vomiting, right? uh, where when the patient will present with the diarrhea, they just give ORS, right? But they don't come out with the diagnosis. So we have seen patients presenting with pneumonia treated as simple diarrhea illness, urinary sepsis, meningitis, systemic sepsis treated as diarrhea. Though they present with diarrhea, it's a parenteral diarrhea. There's a systemic cause, so that should be diagnosed and treated. Vomiting. So many times we have seen patients presenting with vomiting treated as simple vomiting, but they don't investigate further to see the cause of vomiting. Metabolic causes presenting with vomiting, cardiac causes of vomiting. We have a child with dilated cardiomyopathy. Just people treated for 6 weeks for vomiting. Surgical causes, hypertension presenting as vomiting, renal, liver, medications causing vomiting, poisoning, and so on and so forth. And simple diseases like which pediatricians should not miss, like meningitis and pneumonia are treated like Kawasaki disease and so on and so forth. So why do we go wrong? One thing for trainees, I always tell them there are two things. You diagnose based on history, examination, investigations, and the cause of illness, and when it is compatible with diagnostic criteria, that is known as a diagnosis. You just stay 8 feet away from the bed and you just tell, okay, this is meningitis, this is Kawasaki disease, this meningitis, encephalitis. That's called labeling. Yeah, you just label it without any compatible signs and symptoms. And people diagnose meningitis even without doing LP. So LP is diagnosed. If you want to diagnose meningitis, you have to do LP, right? And Kawasaki disease, right? People without a single criterion, they make a diagnosis of Kawasaki, and they do the wrong test and they say meningitis excluded. So I have seen diagnostic cards saying that meningitis excluded, presenting with subdural effusions. Why did they miss meningitis? Because ultrasound scan said no evidence of inflammation. So they do a wrong test and come to a wrong conclusion. Surgical cause of abdominal pain is excluded because child is in the medical ICU. Just because the patient is in the medical ICU or the medical unit, they don't think about surgical cause. So we have seen those things as well. Where do we go wrong? Not using diagnostic criteria, right? It's like when you go for the final MBBS exam, they do everything and then say, okay, what is your diagnosis? Nephrotic syndrome. Are you sure? They say, shook their head and say, no. So what else? It's nephritis. Then when you ask, okay, are you sure that it's a nephritis? They say, no, it's nephrotic. So because they don't know the criteria for nephrotic syndrome or nephritis. So same thing occurs even with the, right? So second, because it's very, very important, right? If you want to learn only one lesson, learn that one. Use the diagnostic criteria to diagnose the illnesses. And second problem is never thinking of differential diagnosis. They just straight away, from the history, examination, investigation, everything, just one diagnosis, that's it. Whether it's compatible or not, one diagnosis. Recently, we had a child who presented with swelling and admitted to the hospital 3 times, and then ultimately presented to our unit, intensive care unit. The diagnosis card said nephrotic syndrome is excluded. That was the diagnosis. In fact, this child had dilated cardiomyopathy. That was the cause of swelling, periorbital edema. Again, as I told you, wrong conclusion based on wrong investigation, right? And recently we had a patient whose procalcitonin, which is supposed to be a very sensitive marker of infection, completely normal, PCT with huge subdural collection and the midline shift. And also, you should always ask to fine tune your diagnosis, ask what are the symptoms and signs which are against my diagnosis. That will fine tune your diagnosis. The other trick, if you want to learn, is do not accept some other's diagnosis until otherwise it fulfills the criteria. Just because somebody says this is this, don't believe that. Another way to fine tune your diagnosis is, you have to revisit your diagnosis, critically analyze even your decision, right? You would have made a diagnosis today of this, but critically analyze and see whether this patient is fulfilling all the criteria for diagnosis. And the other example of why we go to make mistakes is not using clinical or the common sense, or sometimes we don't use our we lack confidence in our all clinical acumen. For example, we had a child whom we thought there's a meningitis and complication of meningitis, but the ultrasound said completely normal. We persisted and we argued with the team, and we forced them to do the CT, which showed huge subdural collection with a midline shift, and child underwent about 5 neurosurgical procedures following that. Again, we had a patient transferred to us as Miss C, and then we contested, and there were some other investigations which was so people were holding on to the diagnosis of polymyositis. We said no, and we persisted, and we proven to them that it is actually not a case of MIS-C or polymyositis or the mixed connective tissue disorder. It was actually pyomyositis. So those errors are very common. So then another fault that we make is only depending on investigations reports for diagnosis. You have to have a differential diagnosis, and to prove or disprove, you have to do the investigations. For example, we have seen people going wrong, saying that okay, dengue excluded because of NS1 antigen is negative, and sometimes people they don't know how to interpret the results. Recently, we had a patient sent to us as Miss C, and to see actually that was a mycoplasma infection with D dimer was sky high. And also we might go wrong because not doing for what is necessary. For example, we had a patient where HRCT was done and they said foreign body excluded, but we persisted and we said okay, go ahead with the bronchoscope, and there was a foreign body and the patient survived. Very important is forgetting our basics, and also don't depend on the juniors for your history, examination, investigations. Sometimes I personally go through the history, I personally examine the patient, not on sometimes if I am not very clear with the history, I personally go through the history, I personally do the examination, investigations, and we follow the course of illness, and also we critically analyze and revisit our diagnosis. Those are very important factors for missing diagnosis, not to miss for treatment errors. It's extensively used. For example, status epilepticus, right? As a medical student, we were taught from third year, as a third year medical student, we are taught status is only 30 minutes. After 30 minutes, the patient should be in the seizure activity is controlled, and the patient should be in the HDU. We are monitoring the patient. If the seizure activity is not controlled after 30 minutes, child should be in the ICU with thiopentone infusion. So simple. But we get ICU request saying that we have a status epilepticus which has been going on last 72 hours. So this is one of the treatment error, right, which we frequently encounter. Then the scared of side effects and they don't give boluses. For example, again status epilepticus. You ask, why did you give phenobarbital bolus? So we are scared of respiratory depression. So what will happen if you don't give? The patient will die. So dying is all right rather than having side effects. Again, septic shock. We very frequently see, why did you start inotropes? Patient is in severe shock. Why did you start? No central line. There is no problem starting inotrope through the peripheral line. So what I have done up to now is we are talking about problem, impact, classification, and fourth part of the presentation is patient safety. Especially I will be concentrating specifically on the medication safety. So from the words, it's from the WHO, the definition: cultures, processes, procedures, behaviors, technologies, and the environment in the healthcare that consistently and sustainably lowers the risk, reduce the occurrence of harm, make errors less likely, and reduce the impact of the error when it occurs. That is the definition of the patient safety. If it is difficult for you to digest, go to this one, which I have presented to you earlier: a world in which no one is harmed in healthcare and every patient receives safe and respectful care every time, everywhere. Even if it is difficult, probably you can hang on to this one. No one should be harmed while seeking healthcare. It should start from the policymakers. It could be the government, it could be the ministry, and it could be the colleges, right? Recognize the safety as the priority in the policies and the program. All the policies and the programs, safety should be the one of the priorities, and there should be a safety programs which are supported by our policy. And we have to work in collaboration with experts in this field, like WHO's other organization which are concerned about the patient safety, and patient support organization, and so on and so forth. We have to work in collaboration because they are the expert on this. At our institution level, we should create a working culture, which is very, very important. And also we have to give the leadership, and we should have the patient safety guidelines. We should have the patient safety protocols and the standing operating procedures. I'm not talking about the like a meningitis guideline. I'm talking about for the patient safety guidelines, patient safety protocols, and the standard operating procedures for the patient safety. And these things, no point having it, but every maybe 3 months or 6 months, we have to review this in our management committee meetings. Leadership and culture, as I said, is very, very important. The worst mistake you can do is selecting the wrong priorities. People think we are there to protect the people, the healthcare staff who committed medical errors. No, you are not there to protect the person who has committed medical error. Our primary responsibility is patient safety. Recently, I had a problem where a child, a previously healthy child, well-grown 10-year-old child, presented with respiratory distress. Throughout the night, the HO struggled to manage this patient, but SHO from home, even he has not come to the hospital, manage this child with sedatives. In the morning, when the child developed a cardiac arrest, child was sent to the ICU, and there was a severe pneumonia and the pneumothorax. That was the cause of death. The problem was with the medical officer who treated with sedation. So when we brought up this issue, everybody wanted to protect the person who committed the error, not the patient side. So this leadership and culture should be established. Implementation, you can divide into various categories: surgical safety procedures, medication safety, blood transfusion safety procedures, radiation, immunization, medical devices, infection control. I'll concentrate on the medication safety. And also we have to build a high reliability system and organization. What does it mean? It's actually again the safety culture and the leadership. We have a system where nothing can go wrong, and it's a foolproof system. So you don't have to have a foolproof human being to be there. The system is foolproof, so that there can nothing can go wrong in this setup. Having said that, GMC newsletter says prescription error is 1 in 6 in UK with all these safety measures, while all the safety measures are in place. What about Sri Lanka? We don't have any safety measures. You can imagine the incidence of prescription of the medication. It's from the NHS. Total errors, there were 237.4 million errors, and it costed the NHS 98 million pounds. And every year, about more than 700 patients die of medication errors. So the commonest is administration errors. Next is the prescription errors, where you and I are responsible. And the next one is the dispensing errors, where the nurses and the pharmacists are concerned, right? And there are also other errors like transcription errors. And when it comes to the ICU, errors are 7 times more likely in the intensive care unit. Doctors are accountable for 72% of the errors, and prescription errors are double when the new doctors join the rotation. Medication errors, some literatures are available. 50% of the time, the prescription is not readable, right? Okay, WHO has set a goal by 2020 to reduce the severe avoidable medication-related harm by 50% globally by 2022. Correct me if I'm wrong. I have never seen, at least in my hospital, there was no initiation was taken to reduce the medication safety as set out by the WHO. And even I didn't hear any initiatives in Sri Lanka. Well, our prescription charts are very, very poorly designed, right? And most of the time transcription is done by the nurses. So it's a time bomb, right? It's an error waiting to occur. So prescription and transcription should only done by the doctors. That's what happened in other countries. I told you our prescription charts are poorly designed. It should have at least 4 pages, like this. So these should be clearly mentioned in capital letters, so that the chances for errors are very minimal. The second safety culture I would like to introduce is always use formulary to prevent errors, right? In medical intensive care of Sima Bandanaga, we have gone one step further. We have summarized the important factors from the BNF into one single page, so it's easy for doctors and the nurses to go through. And I tell you, many doctors cannot recall even the correct dose of paracetamol. For example, oral dose, IV dose, a pain control dose. So Even if they don't know the paracetamol, then you can't expect other, dose of other drugs. Other safety culture is, for example, we say zero should always lead and never follow a decimal point. Say this one, right? Go through 0.2, 0.1 milligram versus 0.1. So this first one can be interpreted as 1 milligram. Then there's a tenfold error. Or it can be 1 milligram can be written as 1.0 milligram or 1 milligram. When then 1.0 can be read as 10. So it can cause 10 times higher dose. Again, the microgram and the milligram. When you use the abbreviation, both looks same. So there's 1,000 times error. Again, safety culture, you should be very careful. This is not lecture on pharmacology, right? There's a ceiling dose. For example, if you calculate the gentamicin for a 100-kilo child, it's very high dose. PRN medications, when you prescribe, you have to be very careful. Like, if you say ondansetron 4 milligram as necessary, right? They will give ondansetron every hourly or 2 hourly. So the next day morning, when you come to the ward round, the patient will have ondansetron toxicity. Unit dosing, again, this is also very important. Standard dosing or dilution format should be used. Don't go and start diluting drugs as the way you want. So whenever we use standard dilution charts, 1 ml wherever you are is equal to certain micrograms per kg per minute. For example, adrenaline, we always use 0.3 milligram per kg, whether you are in America, UK, Australia, or Singapore. So if you dilute, 0.3 milligram in per kg in 50 mLs, that's equal to 1 ml is 0.1 mics per kg per minute. 10 ml is equal to 1 mics per kg per minute. So everywhere is the same. And the availability of information, the point of care. Sometimes, you write in the prescription chart, and you copy that, you do various things. Once you come to the patient, there's no way to identify the patient, and there's a potential risk that wrong patient can be given the correct dose. So the patient identification bands would be useful. Sometimes a color coded would be very useful, right? And more useful is a barcoding, so you can't go wrong. And centralized supply, that's also very important. For example, there was a study where they compared the mixing of the drugs by nurses and the pharmacists. When the nurses are involved, the mixing error is doubled. And in many developed countries, they don't store concentrated solutions. For example, concentrated potassium solution in the wards. That should come from the central supply division. So, for example, simplifying things like 5 hours or TRAMP, like time, check the time, approved amount, and the medication, the patient, right? Double checking, even in emergency, it's very important. Person should, two people should check the drug always. And education training is very important. And using pharmaceutical softwares, or you call it a computerized physician ordering entries, also could reduce complications. One of the other culture that we have in developed countries is inclusion of pharmacists in a ward round. So they identify prescription errors, transcription errors, dosing errors, drug interaction, drug allergies, duration of the drug, errors, and the drug level errors. So that's very useful. Strictly speaking, this is not the medication error, but the equipment error. It's very important. In these two machines, SIMV is not the same. In the Newport machine, SIMV can be pressure control or volume control. In this particular model of the Draeger, SIMV means only, they call it SIMV, is only the volume control mode. So a person who is trained, or doctor who is trained in Newport, can't come and just operate Draeger just because it says SIMV. And the other potential error which I have seen is like having many types of machines in the unit. So it's better to limit the number of different kinds of common equipments. So if you have one single brand of ventilator, it will be easy to understand. Well, the other error, for example, is in the neonatal units, they have neonatal, pediatric, adult modes containing ventilators. So why do you have adult mode of ventilator in a neonatal unit? So it's a very potential place to occur error. So if you are a neonatal unit, it's always better to have the dedicated neonatal ventilator. Okay, how to manage medical errors? One of the things I would like to introduce is a critical incident reporting system. That's a feedback loop, and also using the protocols, communication, quality, technologies, training, and patient safety. More to finish this talk. Uh, what should be done when there's a medical error? For example, the morning run, you see that your colleague has prescribed 10 times overdose of antibiotic which was given in the night, and last 6 hours the patient's vitals were stable. And what would you do? The knee-jerk response that I get from my trainees, most of the trainees, is sweep under the carpet. They give two options, genuinely talking, like they say, I'll hide it or I'll alter the record. These are the commonest response that we get from the trainees. Sweeping under the carpet is a crime. Committing a medical crime it may be called as mistake. But if you purposefully hide the error, that's a crime and the punishable offense. So what is the knee-jerk response? It depends on the who you are. If you are the person who prescribed nutrition, sometimes people go put onto the turn onto the defensive mode, and some if it is that someone else, you sweep under the carpet. Very very rarely the SHOs or the registrars or the research registrars, they bring it to the consultant's notice. And if you are an administrator, you put on the blame and you start blaming and punishing. So everything is wrong, right? So we have serious lapses in this country. How to manage medical errors? There's lack of knowledge, and you don't know what to do, and many people don't know how to prevent it. And there's system error, right? There's no proper system for investigation and management. And the culture, right? Working for the patient safety, it's very, very, actually in the primitive level, right? And people think divulging medical error to consultant or superiors is a crime. Divulging, they think, is a crime. And of course, you have to, in a proper setup, you have to divulge the information, medical error to the patients as well, patients and the relatives as well. Knowledge is very important, but even not only it's not only the part of knowledge, right? Even I have had some senior registrars who have completed their foreign training. It's not only the pediatrics. I train about 7 categories of postgraduate trainees, right? They say even after foreign training, they say, okay, we will sweep under the carpet. So that's wrong. In Sri Lanka, what we focus is individual, right? Whoever made the mistake, we want to punish them. We don't focus on the system. But other countries, focus on the system. So the problem is not because of the simple error of a person. It's a collective error of the materials, methods, machineries, measurement, and the manpower. So if it is difficult for you to understand this one, for example, medication error, it's maybe the equipment label was not clear, the people involved maybe nurse was distracted, environment was a busy place, this process was not supported by the pharmacist, and there were no process were involved to stop this one. So everything, it's a cumulative effect only the medication error. So we focus on these things. In our system, we focus. It's like killing a mosquito. We find the weakest link to punish, right? But in the developed system, it's like, cleaning the mosquito breeding place. So, as I told previously, we should have a system which does not rely on the perfect human performance. So we have to build a foolproof system so where things cannot go wrong. We are aware of these reasons, Swiss cheese model. So when all the protective layers are aligned perfectly, then only the adverse event happens. So when the critical incident occurs, it should be notified, it should be reviewed, collect the facts, then we analyze and we determine the outcome, and we provide the solution, and then we will with this one. This notification is very, very important feedback. If you don't notify the incidents, then nothing can be done. The one of the important aspect of notifying the incidents are to actually what surface is the serious incidents only surface. All the others are like it's like a tip of an iceberg, right? So all the other problems like a non-fatal issues, near misses, and unsafe practices which are there in your unit will not come to surface unless you investigate. So this reporting is very, very important. Certain things are mandatory. You have to, if you don't, report, your registration can be cancelled, or so you have to face a very serious consequences, right? For example, serious incidents of a death of a patient, you have to divulge that information. And there's a voluntary reporting system for minimal harm. So where there's no penalties or fines are involved, those things are very confidential. By hiding or by lying or being dishonest, you are not suitable to be in the profession, because it's very important to identify the ways to prevent the medical errors in the future. For example, there was an incident of self-extinguishing. One senior registrar or the registrar can consider this as just one of this thing. But for a consultant, serious issue about the monitoring. We want to know whether the nurses and the doctors were present during that time of self-extubation. There was a serious concern about the airway management, whether the tube position was in correct position. There was a serious issue about anchoring the tube and weaning and the extubation protocol. This tiny baby decided to pull out the tube, right? So then your protocol, is not useful. You have to revise your weaning protocols, right? There's a serious lapses in the sedation protocol, and there are many safety issues. For example, the routine care. So whether they are doing it properly or that causes problem. So there are multiple concerns for a such single incident. And we have to have a protocol guidelines in the checklist for treatment. Uh, Most of the people think that maximum stand is using protocols. No, you have the minimum stand is using protocols, right? And how frequently you see printouts of protocols in the bedside. We make sure that each and every child with conditions have a protocol put out in the table. So that's a must in our ICU. Not only the protocol, sometimes the protocol is there, people don't follow it. Then better to have the checklist. For example, in septic shock, where with the given oxygen, with the cannula is inserted, blood was sent for cultures. And more importantly, the monitoring compliance also very important. Communication is very important. Quality improvement also part of the safety. And technologies are very useful, and particularly technology can be used for training, for the not only for knowledge, skills, teamwork, leadership, communication, and also um, uh, other soft skills. These are very important, right? uh, So WHO has initiated a flagship initiative a decade of patient safety from 2021 to 2030, but I have not seen any initiatives taking place in Sri Lanka. This was uh, you know, as attitude and the mindset. Zero patient harm in our institutes or in our system. And second thing is build a high reliable system, which we discussed about, and safety in every clinical process we talked about. We took example of medication safety, and patient centered, and patient and the parents and the relative, the family engagement is very important. And the staff training, knowledge, skills, and attitude are very, very important. Research information flow and the critical incident reporting system are very important. There's no proper system in Sri Lanka, and working with collaborating with the experts in this field is also important. So, in summary, we are coming to the end of our session. Medical errors are huge and growing problem. Importantly, most of this patient harm is avoidable. It has a huge impact on individual, family, healthcare staff, and the healthcare system. Uh, there are various patient safety measures available. Policy level, we have to make safety as a priority. Institutional levels, we have to inculcate safety culture. Critical incident reports are very, very important feedback loops. Using protocol guidelines, checklist, proper communication channels. I didn't concentrate on that one. And the quality improvement through the benchmarking, audits, and the accreditation are also very, very used. Technology can also be used. Finally, I would like to remember these words. What we want is a world in which no one is harmed in healthcare, and every patient receives safe and respectful care every time, everywhere. If it is difficult for you to remember this. No one should be harmed in our institutions. Thank you very much. So, uh, you know, Hippocrates must be laughing at us, right? We say primum non grave, but the third leading cause of death is due to medical errors. He must be asking us, this joke, right? And I think I justified my title, primum non nocere. First, do no harm. It's an impossible Hippocratic oath right now. Thank you very much for patient hearing.